Good morning, everyone. Today I will be talking about habits. Coming to the definition of habits, a habit can be defined as a tendency towards an act that has become a repeated performance, relatively fixed, consistent, and easy to perform by an individual. So, coming to classification of habits, habits can be divided into useful habits, harmful habits, empty habits, meaningful habits, pressure habits, non-pressure habits, biting habits, compulsive habits, and non-compulsive habits. So, coming to the first habit, that is thumb sucking. So, thumb sucking, we have one definition, that is digit sucking or thumb sucking is defined as a placement of the thumb or one or more fingers in varying depths into the mouth, and till the age of 3 to 4 years, thumb sucking can be considered as normal. If the habit persists beyond this age, it can lead to various malocclusions. So basically, the etiology of thumb sucking is divided based on three theories. First one is a Freudian theory, second one is a oral drive theory, and third one is the Benjamin's theory. So in Freudian theory, it was proposed by Sigmund Freud, and the child is going through various distinct phases of psychological development, of which oral and anal phases are seen in first 3 years of life. So in the oral phase, it's believed that the mouth is a center of attraction. So according to oral drive theory by Sears and Weiss, it is proposed that the prolonged suckling can lead to thumb sucking. So the third theory was Benjamin's theory. So according to Benjamin, a rooting reflex is the movement of infant's head and tongue towards an object touching his cheek. So reflex disappears in 7 to 8 months of age. So the thumb sucking arises from the rooting or placing reflex seen in all mammalian infants. So basically it is divided into different phases. So phase 1 is normal and subclinically significant, which is seen from a child's birth to 3 years of age, and phase 2 it is clinical significant sucking from 3 to 7 years, and time to initiate treatment to solve dental problems related to digit sucking. And phase 3 it is known as an intractable sucking. So thumb sucking, which persists after 7 years of age. An integrated approach by dentist, psychologist and physician is required if the patient have the phase 3. So effect of thumb sucking on dentition and facial skeleton. So there are majorly trident factors they are telling. First one is the duration of the thumb sucking, second one is frequency of thumb sucking, third one is the intensity of thumb sucking. So other possible factors are position of thumb or fingers in the mouth or associated muscle contraction of the lips and cheeks. So there are many some clinical features which you can identify in a thumb sucking patient. So it includes a proclination of your maxillary anterior teeth, or in some patients you can see increased overjet, or in some patients even an anterior open bite can be visible. And patients having thumb sucking might have narrow maxillary arch because of the contraction of some cheek musculature and posterior crossbite, and some patients will have a development of tongue thrust habit due to anterior open bite, and hypotonic upper lip and hyperactive mentalis muscle activity can also be seen in thumb sucking patients. So coming to the diagnosis of thumb sucking patient, so the parents should be questioned on the frequency and duration of the habit. So parents will know the better thing about the diagnosis of thumb sucking. So an intraoral clinical examination will reveal presence of thumb sucking habit. As I mentioned already, the clinical features, you can examine the clinical in the clinical scenario cases. So coming to the management of thumb sucking, so that is divided into three main headings. The first one is a psychological approach, where you need a parental counseling, and the second one is mechanical aids, where it is divided into removable and fixed. You can give either the removable tongue grip or soldered grips for the patient having the thumb sucking. So there is one more method, that is chemical approach. So use of a bitter tasting or foul smelling preparation is placed on the thumb. For example, it is quinine asafoetida or pepper dissolved in a volatile medium. So coming to the next habit, that is tongue thrusting habit. The tongue thrust is defined as a condition in which the tongue makes contact with any teeth anterior to the molars during swallowing. So in the picture you can see how a tongue thrust habit looks like. So coming to the etiology, it is divided into various etiologies. First one is a genetic or a learned behavior, maturational, mechanical, neurological or psychogenic factors. So first one is a genetic. So it can be hereditary, it can be transferred as an etiological factor, and learned behavior, which means improper bottle feeding or prolonged thumb sucking habit or prolonged tonsillar and upper tract infections can lead to tongue thrusting habit. Or the next one is a maturational factors, like tongue thrust can present as a part of normal childhood behavior that is gradually modified as the age advances. So next one will be your mechanical restriction, like macroglossia, constricted dental arches, enlarged rhino can also lead to a tongue thrusting habit. And next one is your neurological disturbances, like any hyposensitive palate, or there is any disruption in the tactile sensory control and coordination of swallowing because of inadequate underlying skeletal-dental configuration. So the last one will be your psychogenic factors, some like substitution of tongue thrust for forcefully discontinuation of fungal sucking or exaggerated motor image of tongue can result in development of your tongue thrusting habit. So classification of tongue thrust by James. It is divided into 4: type 1, type 2, type 3 and type 4. In type 1 is known as the non-deforming tongue thrust. Type 2 is deforming anterior tongue thrust, which is categorized into 3, and type 3 is deforming lateral tongue thrust, which is categorized again into 3, and the last one is type 4, that is deforming anterior and lateral tongue thrust, which is divided into anterior and posterior open bite, proclination of anterior teeth and posterior cross bite. So coming to simple tongue thrust, how you can differentiate between a simple and complex. In simple, there will be the contraction of the lips, mandibular muscle and mandibular elevator muscles, and the next one will be the teeth are in occlusion as the tongue protrudes into an open bite, and there is good intercuspidation of posterior teeth and good occlusal fit. And in complex tongue thrust, it is also called as teeth apart swallow, and there is contraction of lip, facial and mandibular muscle, no contraction of mandibular elevator muscles, and there is poor occlusal fit and stability of intercuspidation. So by differentiating these features, you can tell whether the patient have a simple tongue thrust or a complex tongue thrust. So coming to the clinical features, so similarly to the thumb sucking habit, you can see proclination of anterior teeth, anterior open bite and maxillary protrusion in tongue thrusting patients, and posterior open bite in some patients, and lateral tongue thrust can also be seen, or posterior cross bite. So management of tongue thrust includes habit interception. So you can give any removable appliances or fixed appliances like ribs or rakes in some cases, or in other we have to completely treat the malocclusion. So once a habit is intercepted, you can start or continue the braces treatment, which will help to correct your malocclusion. So coming to the next habit, that is mouth breathing. So mouth breathing may result as an altered jaw and tongue posture, which could alter the orofacial equilibrium. And most normal people indulge in mouth breathing when they are under physical exertion, such as during strenuous exercises or sports activity. And it is again divided into obstructive, anatomic and habitual. So in obstructive, it can be because of any obstruction in the pathway of your respiration, like a DNS, deviated nasal septum, nasal polyps, or any other chronic inflammation, tumors, or any other allergic reactions can lead to obstructive mouth breathing. Anatomic means if you have any problem with the lip morphology or any short upper lip cases, you can have an anatomic mouth breathing. And habitual, which means if you have any other habit, like a mouth breather is one who continues to breathe through his mouth even though the nasal obstruction is removed. So in such cases, or in this, the mouth breathing becomes a deep-rooted habit and is performed unconsciously. So coming to clinical features, so there are some features where you can identify whether the patient is a mouth breather or not. Features like long and narrow, pigeon-like leptoprosopic face, narrow nose, short and flaccid upper lip, contracted upper arch, and expressionless face, increased overjet, anterior marginal gingivitis, dryness of mouth, or anterior open bite can also even to occur. So coming to diagnosis of mouth breathers, you can see the patient's history, clinical examination, cephalometrical data, rhinomanometry, like a study of nasal airflow. You will see how the patient is having a mouth breathing or not. Coming to management of mouth breathing, you have to remove, if patient have any nasal obstruction, you have to remove the nasal obstruction, and interception of the habit or RME can also you can give. So coming to Bruxism has generally been defined as a clenching or grinding of the teeth. So in according to Roland Tanesio, there is 87 to 88% in children and 15 to 90% in the adult population. So the etiology can be because of psychological or emotional stress, occlusal interference, or any pericoronitis or dental pain can also trigger the Bruxism. So coming to clinical features include occlusal wear facets, fracture of teeth, teeth mobility, tenderness, muscle pain, or TMJ pain. And the diagnosis, you can check the history and clinical examination. If there is any occlusal prematurities for the patient, you can see that using articulating paper, or you can even check electromyography if the patients have any hypertrophic muscles of mastication. So management, you can even give emotional and psychological disturbance. If a patient we have to address that, or any hypnosis. If patient have any occlusal prematurities, you can give occlusal adjustments, or night guards or occlusal splints can also be required. So coming to lip cheek biting, it is otherwise known, lip biting and lip sucking may appear after forced discontinuation of thumb or finger sucking, and it usually involves lower lip which turned inwards. So clinical features include proclined upper anteriors, retroclined lower incisors, hypertrophic lower lip, or cracking of lips. So management includes, you can give a lip bumper or an oral stream for the correction of these habits. So the last one is a nail biting habit. So nail biting does not produce any gross malocclusion, but it can cause some rotation of the incisors or wear of the incisal edges, or some minor crowding. And nut notch is a classic feature of a nail biting patients. Thank you.